And this is Future 5, and it's showing improvements in ACR 20 and 50 response rates through week 24. And here we have 300 milligrams of Secukinumab. The blue is with 150 with or without loading dose and placebo. And you can see the ACR 20 responses up over 60% and high responses also in ACR 50. So undoubtedly it works for arthritis. And this is looking at the long term. And one of the features of Secukinumab is when started early, especially, it has very good retention rates. These are the ACR 20, 50, and 70 response rates up to 5 years. And you can see they are sustained ACR 20, ACR 50, ACR 70. So there's no doubt it's an effective treatment for joints. And one of the things you want to prove is that it inhibits radiographic progression. And here we look at anti-TNF-naive patients in whom it's the first biologic DMARD as recommended by EULAR. And you can see that the 300 milligrams virtually has no damage. And actually there's an improvement in the modified Stokes score, in the ACR, in the score, a radiographic score, which is actually the modified total sharp score. And in the anti-TNF incomplete responders, you can see, again, there's a major reduction in the damage that occurs. But obviously, the most effective treatment is to treat it early. When you've already failed a TNF, the response rate of all therapies is reduced. And this is showing that there's no radiographic progression in up to 90% of patients treated with Secukinumab, with taking the modified total sharp less than 0.5 as the definition of no radiographic improvement. So very good radiographic improvement as well as symptomatic improvement. And these are showing the data here with the 3 groups. Just to note that the normal dose is 150 for psoriasis, but if you have severe psoriasis or there's any need to increase dose, you can go to 300 milligrams. The very difficult to treat enthesitis and dactylitis are also part of the GRAPPA treatment pathway. What are the data for Secukinumab? Well, you can see early on at 6 months, there's a complete resolution of over half the patients, 60 plus. At the end of 5 years, it goes over 80%. And in Future 2, similar sort of results with very high rates of resolution. And enthesitis, of course, is very difficult to treat. Dactylitis, if anything, is even better in Future 1 and 32, 70% plus at 6 months, and up to 5 years, over 90%. In Future, just a little bit less than that. Finally, there's skin. And this is where Secukinumab really sets new standards. This is PASI 75, which we just used to dream about when we were treating psoriatic arthritis and skin disease. That's a major improvement, and that's seen at 6 months in 63% and 55%. And by the end of 4 years, you're seeing nearly up to 90%. And PASI 90, which is virtually resolution of psoriasis, figures only slightly less. So this is really remarkable data. And it's the data which EULAR suggested you should use IL-17A inhibitor for if you have major skin disease. Now, axial disease in psoriatic arthritis has been little studied. In fact, the MAXIMIZE trial is the first one that is, in a proper RCT, has looked at the ability to treat the axial manifestations of PSA. And you can see in the first 12 weeks, when there's a placebo control, there's a major difference in advantage for Secukinumab. And then when you switch, there's a recovery in the ASAS 20 response. ASAS 40, the same occurs with major improvements, very little seen in placebo, but major improvements when switching to Secukinumab. And when we look at what happens over time, this is compared to adalimumab, Secukinumab is associated with a higher treatment retention rate than adalimumab, with 86% of Secukinumab patients at a year compared to 76% of adalimumab. So the message in psoriatic arthritis is that it's well tolerated, very likely to stay on drug, and is equal to everything it's been compared with, or better. And just to finish this with an example, this is a not unfamiliar situation. A patient with very long-standing severe psoriasis has a high cancer risk because of recurrent squamous cell carcinomas, probably due to the PUVA, erythroderma, so very bad skin disease, and multiple systemic features as well as bad joint disease. So she needs something that is actually not going to induce cancer and it's been very effective for skin and joints. And she was started on Secukinumab with very good resolution of her symptoms. So with that brief review of psoriatic arthritis, we're moving on to ankylosing spondylitis. And just to note that there's still a large delay in referral of ankylosing spondylitis, which we are in the UK trying to address with better information for GPs. And you can see there are a number of reasons why this occurs. The biggest one, of course, that GPs see an awful lot of non-inflammatory back pain, and it's very difficult for them to distinguish, but they need to keep in mind with red flags. What are the consequences of delaying recognition of AS? Well, late treatment, as I've previously shown, shows decreased function, increased disability, poor quality of life, and has health economic consequences for their jobs. Imaging is integral to diagnosing and monitoring patients. To establish a diagnosis of AS, you need X-ray, but non-radiographic, you need MRI. To monitor disease, you need MRI. And to monitor structural joint damage, you need, or you can use all three, including CT. Anti-TNF therapy was a revolution when it was introduced into ankylosing spondylitis, but still this review shows that 63% only achieve a mSASSS20, leaving 37% receiving TNF inhibitor therapy not achieving mSASSS20 response. So there's undoubtedly a need for new therapy. And as with the future studies in psoriatic arthritis, there have been 5 measure studies with the largest group of AS patients studied, and they've provided a very complete picture of the efficacy of Secukinumab. Here we have measure 2, showing the spinal pain relief as early as week 1, and improvement in the FASIC score markedly occurring up until the 4-year period. You'll note that the dose here is now 150 milligrams. And sustained mSASS20 and mSASS40, which occur through 5 years. And again, the retention rate is extremely high. It works whether they've had anti-TNF incomplete responders or they are TNF-naive. And this is, again, is 150 milligrams, as it always is. But the best response rates in measure 2 were seen in the TNF-naive patients, which is, of course, the ideal, especially when we come to the safety. These are the anti-TNF incomplete responders seen in more detail with a slightly reduced response, as is always the case, ACR20 and ACR40. And as has been seen for psoriatic arthritis and before, the BASDAI improvement is maintained, both for observed and imputed data, as the 2 dotted and full lines are seen. And this study started with Secukinumab IV, but of course we now use just oral subcutaneous loading doses. And in measure 1, which had the most complete follow-up, at 5 years, you see that Secukinumab, both the 150 and the Secukinumab IV to 75 milligrams, had extremely good completer rates at the end of the period, which was 4 years. Radiographic progression in ankylosing spondylitis has been very controversial, and it's been quite difficult to show a TNF. These are showing 3 different TNF blockers and showing that the basic improvement is not really significant compared to comparative data. This is the OASIS long-term follow-up, showing that treatment of TNF is still controversial in terms of its ability to inhibit structural damage. Yet Secukinumab demonstrated no radiographic progression in 80% of patients at 4 years, and this is the modified Stoke ankylosing spondylitis score. You can see that the two doses, of course, this is closer now to the recommended dose. And real-world evidence, again, shows the high retention rate. It's best in patients who are biologic or targeted synthetic DMARD-naive, but it's also pretty good in 1 prior biologic DMARD or 2 biologic DMARDs.
We have 1 minute now.
You have, we know in patients who are naive to TNF, you do get the best response. And because it's a safe drug, which we'll see in a moment, it has the advantage of patients being unlikely to stop because of side effects. The SURPASS study design compared head-to-head with adalimumab, which is also always useful to show. And what they show in this study is that for mSASSS 20, there are at various time points significant benefits for Secukinumab over probably the commonest used biologic. So I've mentioned the side effect profile. This is looking at the side effects in the 3 programs, psoriatic arthritis, and AS. And they really are not traumatic at all, with viral respiratory tract infections being the major side effect. And looked at in the areas of special interest, again, what we're seeing here is psoriasis, psoriatic arthritis, and AS. And if we look at serious infections, these are per 100 patient years. And these are roughly about 1/3 of what we see with the TNF inhibitors. There is the known problem of candida infection, which tends to be mild. There are concerns because TNF blockade does not work in inflammatory bowel disease, but the incidence is actually extremely low. If we look at psoriasis, for example, it's 1 in 1,000, which is probably less than the incidence that would occur. It's difficult to measure, of course, in AS, which does have inflammatory bowel disease anyway. Uveitis, Secukinumab isn't the first-line treatment for uveitis, but it doesn't seem to exacerbate it, and then probably when patients are well treated, it actually reduces the prevalence.